So this is a 40 years old male patient, non-diabetic, non-hypertensive, non-smoker. So on digging for the risk factor, he told he is a tobacco chewer since 10 years, 10 to 20 years. So this is and he presented with the ST elevation MI in inferior leads, and there are the reciprocal changes. So lead 3 is more than 2 ST elevation. So this is the iliacaudal view, and you can see the 40%, 40% lesion in the LAD proximal osteoprox. This is the iliacaudal view, and this ariocaudal view you can see in the osteoprox LAD. There's almost 40% lesion, and this is a epicranial view, and you can see the same thing in the proximal LAD. Non-significant lesion in the LAD, and this is the areocranial view, and as expected this is RCA. You can see how bad thrombus is there in the right from the proximal RCA. He presented with a complete heart block on the ECG with hypotension. The BP was fairly 90 systole. So this is the RCA condition. So after all clearance, we started at the same time. He presented after 2 hours of chest pain. So as he was in the complete heart block with the heart rate of almost 30-40, so we put the temporary pacemaker. This is a TPI lead in the RV, and then with the right femoral root, we started the plasty, and you can see the flow has come. So this is a BMW PTCA wire with this JR catheter. You can see the lesion in the mid RCA. It's a tight thrombotic lesion. So we preferred a direct stenting. This is a stent 3.5 into 20, and this is a stent placement, and this is a stent inflation, and you can see in there's a dog boning effect in the middle of the stent. The nominal was 8 atmospheric pressure, and this was we inflated, and RVP was 16. We inflated up to 14, and sometimes with the reinflation you will get the things corrected. There's again a reinflation of the stent, and then we got, and this is the picture after the stent placement, stent inflation, and the patient got sort of relief for the chest pain, given tarafiban, nicoran, everything, and there's a TME3 flow. So in this cranial view we can see how large the RCA is. The diameter was 3.5. So during the proximal RCA lesion in the ACS, there's always a chance of CHB because proximity of nodal artery in the proximal RCA. So we try to put the TPI, temporary pacemaker. With support of TPI only we do the proximal RCA angioplasty in the ACS. That is the safest. And this patient had a CHB, so straight away we put the TPI, and then we started the plasty. So this is the TPI lead in place. So we'll keep this TPI for almost 12 hours, and then we'll see. So this was the angioplasty to RCA, thrombotic RCA in this young patient who is a tobacco chewer only. No other risk factor.